focus this evening on adult chronic suppurative otitis media. Now, I know we see a lot of children in our surgeries with that problem, but JDIP's going to mainly concentrate on adults hearing solutions to discharging ears. Catherine's then going to go on and look at discharging ears and bone conduction implants, and then Tim's going to give a real-life example of how BAHA can really influence people and the wonders it can do for them.
About 1% of children and about 0.5% of adults in the UK are affected by this big time. Huge numbers globally. 50% of these patients require hearing aids to look after their hearing, the impact on their hearing. The trouble is there's the disproportionate load in the developing countries. So oftentimes there's a tendency in the developed world to dismiss it as a problem of the developing country. You know, you wake up next to somebody with pus pouring out of the ears. It's not the most romantic thing to think of. Equally, people not being able to wear hearing aids and being deprived of their hearing because of the discharge, the hearing aid causing the discharge isn't the nicest thing to have. It's very easy to dismiss it from healthcare providers' point of view. It doesn't happen in that many numbers. There is a mortality link to it, which is not reported as much. All you need to do is go to some of the media, anecdotal articles which are within living memory. One of the best primary care coverages, and despite that, they've had these deaths in the developed world. 80% of temporal lobe brain abscesses are linked to chronic suppurative otitis media. And even in this day and age, with modern antibiotics, scanning, etc., Western Europe, that's the number, that's the prevalence. So 3.24 is a huge number. And that's, if you look at, say, Asia, where it's very high, it's not hugely different. Of all the walk-in complications and emergency take which we have, this is what the 32 were otological in nature in 1 year. This is what you were describing. Sigmoid sinus, brain abscess, number 4. And that's a low number because that you can put that and that in within that category as well. Being in the right place with the right specialist and the right imaging is what makes the biggest difference. Patients essentially have a hearing loss, but they have a discharging ear. These patients, this specific group of patients. So the hearing aids, what do? They just block that ear and cause that discharge to grow. And the way I explain to the patients is a deep dark hole inside the body which is chucking out dead cells all the time, which becomes wax eventually. What we are doing is closing it off. So if you think of living in a cul-de-sac in a troubled estate, there's a whole lot of yobs sitting there drinking and making merry and having lager at night. You can't take the ear out or sell the house and move, so you're stuck really, essentially. And then you close that road off, so there's no police patrols who can come in, so it's even worse. The trouble is, primary care, you're sort of loaded with all sorts of guidelines. And my wife tells me, we in Sheffield we've riddled primary care with a whole lot of guidelines. I won't take this referral because you haven't ticked that box. I won't take that referral, I'll bounce it back. And there are, you know, in between that, there are groups who also screen the referrals, which is not nice. And where do they go in ENT? The junior-most doctor who's just come off and doesn't know what he's doing. It's a vicious cycle that develops as a result. That's what our field was, and we were glad to see we weren't alone. That sort of nub of an idea was sparked, and then we were talking about this when our bone conduction devices were looking good as a potential solution. Delighted to see some of our Dutch colleagues were doing a very similar amount of work because the healthcare system, the primary care coverage was with the secondary care linkages are very similar to the UK as well. So their thought processes were similar. So if we had a consensus meeting looking at a joint approach to this sort of problem, more in Western Europe type of area. It's a drain on the health service, essentially. This is from the consensus meeting, essentially. All these patients are stuck in little silos. They're in primary care, or they're in secondary care, or in community services, and increasingly probably in Specsavers now. The hearing aid technician thinks of the hearing problem, the nurse in the hospital thinks of the discharging ear, Primary care, your aim is you got 10 minutes, you got something to give them, but not necessarily what's going to be able to cure it because you don't have the tools to do that suction. And then your CCG would say, why are you referring so many times to the secondary care? See, it's a complex problem which we can't really solve in one evening. What it ends up is people going through that repeated cycle of visits here, there, and everywhere. And what most people are trying to do is another discharging year. Let me do something and get this patient out of the door as quick as I can. But that's not solving the problem. So the hearing loss is the overlooked side because we think, oh, infection, cure the infection. And I sometimes say, if your eye was pouring pus, you would think of the vision, wouldn't you? Equally, it's the same thing. I said, people put in skewers, biros, knitting needles, and hair grips into the ear. I said, would you do the same to your eye? People are a lot more aware of the eye than the ear, essentially. This is essentially the model of what we are looking at. Oral health, which we talked about at length, linking it up with auditory health, where alternative hearing solutions come in. Stuck in different silos, primary, secondary, but within that secondary care, there are gaps, which we've realized. You know, the patients stuck in our nurses' clinic, patients stuck in our audiology clinic, patients stuck in our clinic. This is one of the best times for this problem to be solved, essentially. Normally, if I would ask any group, if I would say, have you heard of hearing aids? All hands go up. Have you heard of cochlear implants? Majority of the hands go up. Have you heard of bone-anchored hearing aids, middle ear implants? Some. And actually, this is the area which has so far not been covered very well for a long, long time. And that's where the solutions for the chronic suppurative otitis media lie. So if you think simply that CSOM is a problem of outer and middle ear, and these bypass that troubled outer and middle ear and stimulate the intact inner ear. That's the beauty of these devices. Great for professionals to be able to provide that choice to patients, which we never could before. And it's great for patients. Here comes the twist. We won't just fund it, we'll fund bilateral now. So it wasn't bad for patients and for professionals, essentially. And that's a rare positive on commissioning I can throw. So there's 32 different categories, as you know. It's a big, big shift. Cochlear implants, because there was no other solution, did that very well before. Again, we know from cochlear implant world, there's a huge unmet need. There's at least another 60% who are not implanted at the moment. But that's a well-proven case. But none of us here would go to a surgeon and said, put an implant in my head because you've told me to have it. You can't operate on anybody without them wanting to have it or needing it. We did the first transcutaneous one which Cochlear came out with. So we did the first magnetically loaded one, no aftercare, nothing at all, 2 magnets across the skin, and Bob's your uncle, you start hearing again without having the ear blocked up with the hearing aid. Auditory health is not the priority, often the priority of many people, even ear care professionals. I'm not talking of primary care at all. Even in tertiary referral hospitals. Forget about small, community hospitals, DGHs, primary care, this is the tertiary referral hospitals. Creating awareness is very, very important amongst professionals. It's a very hidden kind of problem. Hearing aid isn't a sustainable option for these patients because they are perpetuating a problem which can lead to complications. So I think the sustainability is a very, very crucial aspect of it. Discharging ear clinics are the best thing that has happened to surgeons, essentially. Discharging ear, off you go to the nurse. That's not going to be solved by just suctioning it every day. Oftentimes you kind of fit in more and more people until you're kind of overwhelmed with the work. Oftentimes the patients that are discharged from surgery nominally should have had a slot available to them for discharge. And increasingly now what I see is, and that's been fantastic, training them, the time that they're given, the rapport they have. That's the old world we are all wanting to live in, and the whole health service is pushing us out of that steadily. It's just tiny tweak can make such a big difference. And patients are delighted. From this awareness, there were 6 stuck in such a highly specialized nursing group who hadn't thought of this solution. And we are in the same, we are breathing the same air. No criticism at all. But what I'm saying is awareness changes a lot of practice. Simple. Same thing looking at audiologists, even more complicated. I'm just trying to describe to you the mindset of these people who run the silos, essentially. And I'm not saying that doctors are any better. There'll be groups of audiologists who might not look at bone conduction devices, so they're not really interested in that area, but not benefiting from a potentially simple solution. What we are trying to work out is what the commissioning gains are on this one. We administered some questionnaires to the patients to see what their genuine problems, and then this is the best way to study patient-related, problems rather than us deciding what the problem is. The elderly are actually most affected, surprisingly. Not surprisingly, because oftentimes the skin condition changes. The ear canal skin is thinner, the migration's less, so you get blockage more and more problems with that. They may have had other problems as a child, which may have made them prone to that. Number of visits coming to the hospital, significant in the older population. Awareness and support is lacking in primary care, and it's not difficult to see why after all the discussion we've had. A lot of them have this air conduction hearing aids, the conventional hearing aids causing the problem. Awareness is poor, and they're not aware these things can help. Many have bilateral hearing aids as well, not many. Treatment modality, as you just illustrated, can be variable depending on who they go to. There's no evidence, no solid evidence at all. None of it works. You see, all you're doing is blocking it and chucking in drops to a pile of slime in there. If you think of a bug living in that biofilm, it's just living in that slime, and that whole slime it's a skin problem essentially. It's full, the bug's living in it, and you're chucking drops on that. And I think, what are you going to do to me? I'm just covered in this slime. No problem at all. Increasingly, hearing deprivation is being linked to cognitive decline early. So 20 dB of hearing loss, which is 20 to 40 is where these people fall in, equals 7 years of cognitive decline. That's another area we're working on at the moment. The main thing is the sustainability, essentially. The sustainability of the device. You look at carbon footprint, you look at reduced, healthcare costs from operative interferences, reduced visits to hospital, healthcare time spent on that is enormous. I think the hearing aids have to be looked at in the whole realm of the other options available. None of us would say hearing aids have no place in this world. That's the first choice. But it's not the choice to bang on about or hang on to when it's not doing the job. Initial investment has to come out of some pot, and NHS is very much like, living from financial year to financial year. So you don't see the long-term benefits of that at times. We all need to sing from the same hymn sheet with the patient groups.
One of the reasons for this evening's event is that neither discharging ears nor bone conduction implants are particularly known in the population at large. So we've been trying to increase knowledge in this area. And likewise for patients, when they first get a condition like discharging ears, it's not something they will have heard of, so they won't know where to look for information particularly either. So they won't know whether to turn this way, that way, or somewhere else. So what will they do? Well, of course, they'll Google it. So I put ear discharge as my search term into Google, and I came up with warm compresses, the beloved cotton buds that all audiologists love, neem oil, vinegar, and a garnish of basil and garlic to finish. So not particularly healthy, and information like that can obviously delay patients finding appropriate treatment. What's it like to be the patient whose ears are discharging? Well, it's not easy to talk about or admit to. People tend to recoil from the subject. It's uncomfortable, painful, smelly, unsightly, and embarrassing. It causes repeat visits to GP surgeries. It's time-consuming for GPs, time-consuming for the patients in home and hospital management. And it's very worrying for them because it can lead to or indicate other serious problems, as we've heard. It's a hindrance to hearing aid use while at the same time you need them. So it's a kind of double cruel whammy. It's debilitating, affecting people's confidence and participation, and can frequently lead to isolation and depression. And frustratingly, these patients can often feel like they aren't making any progress either. They may have an undiagnosed hearing loss or difficulty wearing hearing aids, and they're often in an ongoing, unstable, cyclical kind of pattern. So typically in the current pathway, these patients get caught in a vicious cycle that may be something like the one shown there. And this can go on for weeks, months, and sometimes years. Audiologists, when they get patients referred to them, they'll be doing the hearing assessment, finding out the cause of the problem and the extent of it, and they'll be prescribing hearing aids. The aids may well not be in steady use because of the discharging ears, and they may even be exacerbating the situation. So these audiologists will be doing a certain amount of cross-referring of these patients to help them with their ear health, whether back to primary care or to ENT or oral care nurses if they exist in their area. And then these audiologists will be repeatedly seeing these patients time and again. So over the last year, I've been working in conjunction with a number of established centres who offer bone conduction implants. And I've then been offering training sessions to audiology departments in hospitals surrounding those bone conduction implant centres. It's been focusing on candidacy and referral criteria for bone conduction implants, who are the appropriate candidates, and with a particular focus on CSOM patients. Outside of the bone conduction implant centres, regular audiologists have fairly low levels of knowledge about bone conduction implants and their efficacy with CSOM patients. So the audiologists themselves rated their level of knowledge of this area prior to training. 13% of them said they had no knowledge in this area, and 84% said it was very basic. Just because it's not their bread and butter. They're not dealing with it, so they're getting on with their work, doing a good job at that, and not really thinking about something that their department doesn't offer. Prior to training, less than 30% of these audiologists had referred even a single patient for a bone conduction assessment. But after training, 100% of them reported feeling confident to identify and refer appropriate candidates for assessment to their local centre. So we've been following up after the training sessions, and we've seen, encouragingly, increased numbers of good quality, appropriate referrals of patients from centres who'd never referred before. So, for example, around Sheffield, 2 centres within 6 months of the training session had each referred between 6 and 9 patients, having never referred into the programme before, which is obviously really encouraging. The audiologists are the gatekeepers to information for those patients. If hearing aids are working well, that's absolutely great, and that's what we want to stick with. But if hearing aids are aggravating the discharging ear, or they're not being able to be worn because of that situation, then there's a need to look for alternative solutions. So we're only looking at it when we can't go further with hearing aids. So for a bone conduction implant to be effective, there's got to be something for it to bypass. The analogy is like you're driving down a little country lane, you turn a corner, there's a tree down and the road is flooded and you can't get to where you want to go. So frustratingly, you have to take the diversion through another little wiggly country lane to get to the same place. You're bypassing the problem. Similarly, with discharging ears, it's very difficult for the sound to reach the cochlea effectively. So the discharge muffles the sound, the tympanic membrane is perforated so it's not working efficiently, and the ossicles are also surrounded by the discharge, so they're not transmitting the sound very well. But if you take the alternative route and go directly to the cochlea, then that's working, it picks up the sound, and it can be processed from then on and heard effectively. Unlike hearing aids, bone-anchored systems bypass the problem area in hearing and go direct to the cochlea, which means they need less amplification to do the same job for the patient, which leads to good things like less feedback loops and annoying noises and whistles. It leads to a better sound quality because it's going direct to the cochlea rather than having to force its way through the blocked problem area. And it leaves the ear canal unoccluded, which is really important for patients with discharging ears, and often leads either to a cessation of the discharge or much reduced discharge in the future. This is Cochlear's Baha 5 system in situ, and as you can see, there are 2 options in terms of how the sound is transmitted from the external sound processor to the internal implant. On the left, you'll see the transcutaneous Baha Attract system, which has a magnetic connection across the skin and soft tissue. And on the right, you can see the Baha Connect system, which has a snap-on abutment connection. They both work essentially in the same way. The internal parts are surgically implanted during a fairly short surgery, which takes about 20 to 30 minutes. It's done as a day case. In some places it's done routinely under local anaesthetic, other places routinely under general. Number one, the sound processor, which is worn on the bone behind the ear, captures the sounds and turns those into vibrations. Number two is the transmission across the skin and soft tissue, whether by the magnetic connection or the abutment connection. And number three is the implanted implant, which then sends the vibrations through the bone of the skull to the cochlea. So who are they suitable for? Well, CSOM is by far the most common etiology bone conduction implant users. It comprises 50% of adult recipients. And it just emphasises that a bone conduction implant is a positive treatment pathway that should be considered for patients with discharging ears. This is the indications or criteria for bone conduction implants. Useful for people with conductive hearing loss, mixed hearing loss, and also single-sided deafness. And that's what I'm not going to talk about tonight because that's not an issue of discharging ears. These two audiograms are showing what's applicable to people with discharging ears, which is conductive hearing loss or mixed hearing loss. And both of these graphs, which I'll explain, illustrate good candidates for bone conduction implants. So the one on the left, the conductive hearing loss, those symbols at the top of that graph represent the bone conduction thresholds. Those are the thresholds that are heard when someone has a bone vibrator placed on the mastoid bone, and that's sending the sound directly to the cochlea. The symbols lower down are the air conduction thresholds for the right ear, which is when someone's got headphones on and sound is going the whole way through the system. So as you can see, there's a difference between the two, which tells us that there's a conductive problem. The cochlea is working fine, but there's a problem in getting sound to the cochlea. So that person is experiencing a substantial hearing loss because they're hearing those lower down thresholds. They're missing out on a lot of speech, which is that yellow banana. So they've got a substantial hearing loss. But you can also visualize there that if you could bypass that amount of hearing loss and get straight to the cochlea, to those top thresholds, then that person would be hearing really well and would be is an ideal candidate for a bone conduction implant. The graph on the right, the mixed hearing loss, you've got the same thing. It's called an air-bone gap, the difference between the bone conduction thresholds, which are always going to be better than the air conduction thresholds, because the air conduction thresholds, when you have to go through the blockage. But the whole thing has slipped somewhat down the audiogram. So in addition to the conductive element to their loss, this person has got some sort of sensory neural or cochlear damage. So the whole thing slipped down the graph. But again, if you could bypass that conductive element and add some amplification, this person's another good candidate for a bone conduction implant. We're looking for a 30 dB air-bone gap at the frequencies that I've shown at the top there. And there can also be an additional sensory neural component, cochlear damage, to that hearing loss, with the bone conduction thresholds varying between normal, which is the ones right at the top of the graph, and then slipping down as far as 65 dB HL, averaged across those same frequencies. Cochlear's Baha 5 system comes in 3 strengths of sound processor to cope with the different amounts of hearing loss. So there's a Baha 5, a Baha 5 Power, and a Baha 5 Superpower. They're commissioned in one or both ears for adults and children, as long as they fulfill those candidacy criteria I've just talked about, as long as they've trialed an appropriate hearing aid for at least 4 weeks and it's found to be not of benefit or not able to be worn consistently. And they've also got to try a bone conduction hearing device on a soft band to see that it gives them benefit, often enough to motivate them to want to proceed with surgery because it's a scary thing to put yourself forward for. And that's done routinely in all the bone conduction implant centres as part of the assessment. And I'll end with this slide, which just shows some of the benefits of bone conduction implants for patients with discharging ears. There's many and significant benefits.
My hearing loss is caused by middle ear infections, runny ears, glue ears. And if you wear things inside your ear, you just make it worse, far worse. So I had to balance wearing my hearing aids and also keeping my ears nice and dry. It was a spiral going down and down. It affected my health, it affected my personality, it affected everything.
Theatre, cinema, restaurant, party. Tim's tension would build up. He'd start to get edgy, tetchy, because he was worried about what kind of environment he would be going into, whether he could hear, whether he'd make some awful faux pas about something. And that coloured the whole build-up to going out.
It got to me, I just didn't want to go out. I went out reluctantly, and it affects you in the way you are. And then I started using Bahas. Immediately the change came over me. It freed up my ear canals and my ears dried out and my life changed.
Since his new hearing aids, he's become more interested in music, and he will go along for his own sake rather than just my sake.
I was at a restaurant one time, and the waitress, a young waitress, I think she was trying to get an extra tip, she said, asked me what that was, so I explained it to her, and she said, cool, cool. And I've been waiting 55 years to be called cool. So basically, I've become younger. I changed my career. I took over the brief for special needs and computers, got a promotion, and I started doing lecturing, which I still do. I like talking out aloud. I like talking in front of people. I hated it before.
If Tim hadn't got the improvements to his hearing aids, if he hadn't got the Baha, our life would have been very different, and it might even be apart. I'd still want my life, and I'd be going out, and we'd be experiencing two separate lives. Then that's not much basis for a relationship.
Look, it sounds as though I'm trying to overstate the case, but Bahas and wearing this new technology has made me glad I'm alive. It's made me glad that I'm here in Bristol, which is great. It's made me glad I'm married to this lady here. It's made me glad that I can have a laugh. I enjoy life, I'm confident, and I feel good about myself. You can go down in a spiral. You can have problems. You've heard all about the infections that affect you and really come through to you. And you get worried. I mean, you hear about Oscar Wilde, for example. He was supposed to have died of certain things, but he didn't. He died of a middle ear infection that impacted on his brain. You hear about lots of people that come close to things like that. But the thing about it is, I've got my old hearing aid. You get that shoved in your ear. It doesn't give your ear any chance to dry out. And what happens is the infection travels up the tube. And the worst thing about it, it stinks. If you go out and it smells, your confidence just goes down like that. But if you have these things here, you reverse the whole procedure and you become healthier. And it's life-changing, it really is. The frustrating thing about it is that not many people know about it. The other thing I want to mention is also using it with an iPhone. You hate, as a deaf person, using a mobile phone because you get all the background noise. That goes straight into the implants. It's great. And also I've relived my music now. I can listen to music because I can get all my music coming straight there. No leads down like that. It's Bluetooth technology. And because the Americans really insist on equality there, iPhones have to have this Bluetooth facility. So I can literally just tune out and listen to any of my music. Also, you can use your iPhone as an extra microphone by pressing the button 3 times, and you can pass it around like that. The technology is fabulous. If you think of me, I was struggling with that, right? Yeah. Now I can leave a microphone, pass it around, I can get my music in, I can be part of the normal world. So you become more connected. So your confidence level goes up, and you're wanting to mix with other people. It took me a long time to be diagnosed. I was diagnosed initially as being thick, stupid. Yeah, slow learner. But it wasn't, it was middle ear infections. And because my mum used to syringe my ears out, there was no evidence there were any problems there. But as soon as it was diagnosed, you know, I found out a reason, and I had these teachers that insisted on me wearing that thing. So immediately I became part of this school, and I got my O-levels, and then I went on to A-levels, and then went on to degrees and things like that. And then it's that little lady up there. When I met her, I was a Battersea Dogs Home worker. And she didn't feel like marrying a Battersea Dogs Home worker, so she had me retrained as a teacher. That's why I became a teacher. Come here and we do all the presentations and things like that. But when you see a guy like me, Obviously, wonderfully confident, okay? But, you know, I was a miserable old bugger, I really was. And it's changed my life, and it's changed Lynn's life, and it's changed my kid's life. And it means you go out. That's why I do this. I'm one of the volunteers for Cochlear, and I do it because it's important.